Ladies and gentlemen, I'm honoured to be speaking at the combined meeting of the Indian and British Hand Societies. I'm talking about the non-operative treatment of PIP joint injuries in particular, and I want to emphasise gliding versus pivoting, hence the title of my talk. These are the injuries that I'm going to talk about. I'm going to talk about pivoting versus gliding, initially about DIP joint injuries, i.e. Bony mallet injuries, where I first established this concept, and then PIP joint injuries. So what is pivoting? You look here at a fracture subluxation of a PIP joint, and you see that in flexion, the base of the middle phalanx pivots against the head of the proximal phalanx. Why does it matter? Well, surgeons believe that the PIP joint is intolerant of injury. It often gets stiff. It's been suggested that broadening of the base of the middle phalanx gives a bad result. And we know that poor outcomes can be difficult to treat, although we will hear later about various options. This is what we want to avoid, a destroyed PIP joint, which is stiff and painful. So surgeons have operated to restore anatomical alignment. This has often led to x-rays that look very good, but maybe the finger doesn't. And I think we can differentiate better if we consider pivoting and gliding. And I'm starting with DIP joint injuries, where we first did this work. So you see here a bony mallet injury, and our concern is whether the main part of the distal phalanx will sublux, and sometimes even dislocate, as here. So what we do is an extension stress testing. We get the patient to hyperextend their DIP joint, as here, and then take a lateral X-ray. In this first image, we see the finger with the mallet injury and then hyperextended, and you can see that this is pivoting at the base of the distal phalanx. In contrast, this bony mallet injury with a similar size fracture fragment, pushed back in a slightly different way, glides with the base of the distal phalanx remaining congruent on the head of the middle phalanx. When we assess the two groups, those who pivoted had a high risk of subluxations, but those who glided had a low risk, although the fracture sizes were very similar. These are different biomechanical entities. So I'm going to be talking about base of middle phalanx injuries, not head of proximal phalanx, which David Schuring has covered. The base of the middle phalanx is a concave side, and we know that concave side injuries in the wrist and hand are more forgiving. So previously, if faced with a fracture subluxation or pilon fracture, I would use a dynamic external fixator. I think I was often treating the x-rays, and I would put on a frame like this that I described and we reported 20 years ago. Now, I start my assessment with a lateral flexion x-ray. So I get the patient to bend, and if necessary, use their other hand to push the finger down as far as comfort allows. We see here a patient with a comminuted fracture of the base of their middle phalanx, but on flexion, initially on the left-hand image, push down with their other hand, and their right-hand image at about 3 weeks, flexing with their own muscles. They're achieving good movement, and although the base of the middle phalanx doesn't look great, it's clearly gliding. This patient who had a horse rein round her finger presented with a very comminuted fracture with separation of the diaphysis from the metaphysis. We got her to flex. Within a few weeks, she could get down here to about 60 degrees of flexion. And here she was at 2 weeks already with good flexion and has ended up with a very good result. So I encourage the patients to get their hand moving, working with as much as they can comfortably do, and quite quickly they build up the ranges of motion, often assisted by a physio. Here, this patient you thought would need surgery, but with gliding, he got excellent extension and flexion a result I think you'd struggle to get with surgery. So pivoting is the alternative to gliding and would generally give a poor result. The aim of treatment in these patients, I think, is to restore gliding. So if you have this patient with pivoting, I would operate. Sometimes you don't even need to do a lateral flexion X-ray. You know that this patient will pivot and need surgery. If they don't, you get this sort of problem, presenting late with a divot in the head of the proximal phalanx, which is very difficult to treat. So the outcome of gliding is generally favorable. We've treated 15 adults, mainly with border digit injuries, followed up for over 6 months, mainly pilon fractures. Generally, they're comfortable, although with a little stiffness. The ranges of motion are very good, and I particularly highlight the DIP joint motion, which is especially good, and that's a joint that's often very stiff following surgical treatment of these injuries. So what would I do if faced with a patient with pivoting? Well, I aim to restore gliding, and I would use my dynamic external fixator, which we reported 20 years ago. So this is a case with a comminuted fracture subluxation and the extension of the fracture up well into the middle phalanx. We apply one of the dynamic external fixators I described, and you see the base of the middle phalanx isn't fabulous, but we've restored a joint that the patient can move with some gliding. They create their own gliding surface, and this patient ended up with a very good result. So in conclusion, I think gliding is very important. It is the critical issue in finger and thumb joint fractures, and we should look out for it more. If you seek it on a lateral flexion X-ray, I think you'll operate a lot less and you'll have better outcomes in those patients. Pivoting, in contrast, is a bad sign. When you see it, I think you need to operate, not to restore anatomical alignment, but to restore gliding. Thank you very much indeed.